thank you for joining us to our international rounds. And it's my great pleasure to introduce Dr. Heggie, who is the medical director of our CVICU and one of our senior cardiac anesthetists. And she's going to talk today about anesthetic considerations in ACSD. So I'm going to pass the computer to her, and we will start. So, Jane.
Okay. Good morning, everyone. Can everyone hear me? I don't know how I'm going to know that, or
we can hear you.
Okay, great, excellent. So I'm going to take my mask off because it's just me in the conference room, and I'll be maybe I'll put my phone up as a timer, so I just know where I am with time. So good morning, everyone. So my name's Jane. I'm an anesthesiologist. I work here at Toronto General Hospital in the Peter Monk Cardiac Program, and I've been in the congenital heart group for 20 years. I've known Erwin. We were both junior staff and fellows together. And today I'm going to talk about anesthetic considerations. I'm going to talk about anesthetic considerations for the adult congenital heart disease for cardiac surgery and to a large extent non-cardiac surgery as well. And really the anesthetic considerations are the same. It's how big is the operation and what are the physiologic consequences of the operation. I'd like to introduce my team. So I'm just going to go to the next slide. On the next slide is this way. Nope. The next slide. Maybe if I just hit, I need Rafa. Oh, there we are. Great. So this is my team. There are several anesthesiologists that do cardiac anesthesia at Toronto General and participate in the delivery of care, but this would be the coordination team. The beautiful woman on the left is Dr. Marjan Yariani, and she coordinates all care, cardiac, non-cardiac, diagnostic testing. My colleague, Dr. Vegas, is in charge of our transesophageal echo program and is a world-renowned teacher in transesophageal echocardiography. And like me, is an ICU physician, and we both work in the CVICU caring for our patients and delivering care and echocardiography in the operating room. This is me, and on my right is, and on the far right is our new recruit, Dr. William Ng, and he is cross-appointed between the Hospital for Children and Toronto General Hospital, and will be a great asset in bridging the care of adults transitioning to from sick kids to Toronto General Hospital. So today we're going to review the steps in planning for the adult congenital heart disease patient in cardiac and non-cardiac surgery. And there are unique challenges in providing anesthetic care for this special population. And we'll do some case-based illustrative discussions because I find that they're using real patients is a wonderful teaching tool. So using the data from the Quebec group and Dr. Morelli, we can estimate the number of patients in Ontario with congenital heart disease over the age of 18. So this is from her 2014 publication. And at the time, there were about a little over 7 million people living in the province of Quebec. And at the same time in Ontario, there were almost 13 million people. So if we use just the simple fraction, we can estimate at that time there were about 7,000 adults with severe congenital heart disease living in the province of Ontario. And so Ontario is this little red blotch on the map of Canada. And for those of you that are joining us from outside North America, Canada is the second largest nation in the world next to Russia. And so we have immense distances that we have to deal with for patients with congenital heart disease to travel to reference centers. And what's illustrative is in the province of Ontario, we are the only center that does complex adult congenital cardiac surgery. So patients have tremendous barriers to access care and to get to see us. So in Ontario in 2019, we had 15 million people. So if we take that same fraction moving forward, we have about 9,000 patients with severe congenital heart disease and a little over 80,000 with congenital heart disease that is both simple, moderate, and complex. And I would suggest that patients, even with simple congenital heart disease or moderate congenital heart disease, have special anesthetic considerations under anesthesia. And there's no way that one hospital in Toronto can provide care for non-cardiac surgery for all these patients. So if we take that same fraction and extrapolate across the country of Canada, there's 36 million people, and approximately 20,000 patients with complex congenital heart disease. So how do we deliver care? This is a slide that's going to look at, these are risk factors only for congenital heart disease, cardiac surgery. And we did a retrospective analysis from 2004 to 2015. And I am going to go on and talk about the non-cardiac variables that influence a patient's outcome for cardiac surgery. But what was very interesting in this analysis, we found that living in the Metro Toronto area, so having a postal code that meant you lived in downtown Toronto or the city of Toronto or the suburbs of Toronto, gave you a survivor benefit for cardiac surgery. And I can reassure you that we went on to analyze this further. And we've looked at income, we've looked at access to public transportation, we've looked at proximity to the reference center. And it's the proximity and to some extent income that improves your chances of not having an adverse event, having cardiac surgery. And this is something to consider in countries like Australia, Canada, in countries where patients have to travel large distances to access care. So if we look, going back again to our map of Ontario, and again, this is another publication from Dr. Morelli. If we look at patients with severe congenital heart disease in the year 2010 and extrapolate that to Ontario, she found that in the province of Quebec, that of the 22,000 patients that had congenital heart disease, severe or not severe, 15,000 of them had visits to the emergency department. So we could extrapolate that to Ontario, that 56,000 of 82,000 patients had ER visits. And how many of those ER visits culminated in non-cardiac surgery? Interesting question. So we have to take just a pause for a moment and look at models of care. So in pediatrics versus adult care, in Canada, when you have congenital heart disease and you transition around the age of 17 to 18, you move to an adult model. And so you would likely have been followed at Sick Kids and likely have had all of your procedure as the Hospital of Sick Children. And then when you transition to adult life, you are referred to an adult congenital heart center that may be in Toronto, London, Kingston, Ottawa. However, not necessarily will you get your non-cardiac surgery in that center. And yet, when we look at places like the United States, patients don't transition necessarily to an adult center. They often continue to get their cardiac care in the pediatric center and are often managed by pediatric cardiologists. So my colleagues at Boston Children's Hospital regularly anesthetize patients for laparoscopic cholecystectomy and for non-cardiac procedures in a pediatric setting. So if we look at what are the triggers in North America for transfer from a pediatric setting to an adult setting, we can see that having adult comorbidities is the most common cause, and then age and pregnancy, college graduation. So normal benchmarks in a patient's life of transitioning to adult life are triggers to refer to an adult center and subsequently an adult group of anesthesiologists. So just to clarify, I'm speaking to a group of cardiologists. For the purposes of the rest of this talk, I'm going to discuss severe congenital heart disease and anesthetic considerations. So we will talk about tetralogy, AV canal, transposition complex, and univentricular hearts and Fontans. So this is a study done by a colleague, Brian Maxwell, who is in the University of San Francisco group of hospitals and now works in Oregon. It was a database study looking at the National Inpatient Sample Database and looking at 10,000 adults that had adult congenital heart disease and matched them with propensity matching to a cohort of 37,000 patients. And they did find that inpatient mortality for non-cardiac surgery was increased for adult congenital heart disease, although the risk difference only went from 3.6% to 4.1%, but it was statistically significant. So non-cardiac surgery represents an increasing proportion of adult congenital heart disease admissions. So I'm just going to pause, and this is a slide I've shown many of you in the past. I am of a similar vintage. I don't know if you can see me or not, but if you can see me, you can see that I'm a similar vintage to Irwin Ochlin. And I started my training as a GP and as a pediatric resident at the Hospital for Sick Children and transferred into the anesthesia program. And at that time, and this is the late 1980s, early 1990s, I had been taught that pain was a learned response and that neonates did not experience pain. And although we were transitioning to more humane care and using anesthetic agents in neonates and young children, I would often review an anesthetic record where an infant or may have had an anesthetic for something like closure of a PDA via thoracotomy with only pancuronium, only a neuromuscular blocking agent, and no narcotics and no hypnosis. I think that, you know, there are times where in anesthesia where we highlight all of the positive things we've done, and sometimes we forget about things that maybe we don't really want to bring up. But these articles are from the New York Times. And all of you know how to read, but unanesthetized surgery has been limited to newborns, and the practice had largely ended by the late 1970s. And then you can see that surveys of medical professionals indicate that as recently as 1986, coincidentally the year I graduated from medicine, infants as old as 15 months were receiving no anesthesia during surgery at most American hospitals. So I'm going to go on, and often I like to talk about loss to follow-up, but I have to tell you that when I have my patients in the adult clinic and they've been lost to follow-up for years, and if you ask very open-ended questions like, have you, what surgeries have you had? Have you ever had an unpleasant reaction going to sleep or waking up from an anesthetic? Have you ever had an unpleasant experience while being in an intensive care unit? And if you ask these open-ended questions, I get a hint of why some patients are lost to follow-up. Many of my patients will describe a feeling of loss of control or that they didn't have control over their bodies. Many of them will describe that they have vague recollections of their care, surgical care or perioperative surgical care as a child, and that they can't come up with something specific, but they can tell me that when they're in a hospital, the smells and the sounds make them very anxious. So I don't think it's unreasonable that some of our patients are lost to follow-up because of events that have happened to them in childhood. But I think it's very important that when we engage with them, and as anesthesiologists, we're often, you know, this is an overused word lately during the pandemic, first responders. But often as anesthesiologists, we are the first people to see someone who's been lost to follow-up for decades. So it's not unusual as an anesthesiologist to meet someone who's come in, who's a college student, has thoracotomy and sternotomy scars, and yet they haven't seen a cardiologist in 10 years. Or you may have, you know, be in a community hospital and someone comes in with an acute abdomen and they have sternotomy and thoracotomy scars. And we have to ask these open-ended questions, but we're also in a position where we can say, hey, you look like you've got an interesting problem there. Why don't you go meet my friend Erwin, and maybe you could just go for a checkup and see how things go. So I think it's very important that we acknowledge their faith and trust in re-engaging in the adult congenital heart programs, and also acknowledge their past experiences. And we can't promise that nothing bad will happen again, but understand that these are very human responses to care. And not unlike many of my adult patients who are pediatric cancer survivors, they have similar experiences. But also these patients have social and economic consequences of living with congenital heart disease, hepatic and pulmonary consequences. So again, this is a slide that many of you have seen. It's a multi-system disease living with congenital heart disease, but we're going to talk about the systems that affect your anesthetic care. And it's very important to differentiate if there are 80 to 90,000 patients with congenital heart disease over the age of 18 in the province of Ontario. We can't manage them all at Toronto General. So we have to stratify which ones are friendly telephone advice over the phone and which ones are, what are red flag situations where a patient may have to come to a reference center, not necessarily Toronto General, but maybe the Ottawa group of hospitals, Kingston General, London Health Sciences Centre. You know, you may have to move from a community setting to an academic hospital for your care for cardiac and non-cardiac reasons. So this is just a brief slide. We're going, we have looked at predictors of adverse outcome for non-cardiac comorbidities in cardiac surgery, and I can tell you that the liver is king. If you have severe liver dysfunction, That is the most powerful predictor of adverse outcome, even more so than your anatomical diagnosis. So many of our patients, most of our patients in the cardiac surgery program have right-sided heart disease with congested livers. Many of them have pulmonary insufficiency or tricuspid insufficiency and congested livers with high venous pressures. And although they will improve with their cardiac surgery and we relieve the venous pressures and their congestion, their liver dysfunction is a significant comorbidity to manage and deal with for their cardiac surgery. Most of our patients have restriction when they've had multiple thoracotomies and sternotomies, and although it's very easy to manage these patients intraoperatively and ventilate them, they may be a difficult wean from the ventilator and may require a few hours or a few days to wean from the ventilator and extubate. When you have numerous chest walls and incisions, you also have scarring and increase your burden of blood transfusion. And of course, your anatomical diagnosis is important. The BMI, this is no different than cardiac surgery patients in general. In life, you want to be a little bit chubby. You ideally want a BMI on the high side of normal to reduce your risks of adverse outcomes. People who are very thin, like the patient I saw yesterday with a BMI of 16, and are at higher risk of adverse events or mortality. Patients with high BMIs are at risk of morbidity, but we haven't had any mortality in our program in 15 years with patients with BMIs over 40. So when we're looking at non-cardiac surgery, we have to decide, where does my patient live? What access do they have to care? And this isn't known to everyone outside the field of anesthesia. There are two types of anesthesia providers in Canada. Well, three types. We have anesthesia assistants that can do conscious sedation. We also have family practice anesthesia providers who have completed medical school in Canada and have done a 2-year family medicine residency. And then after 2 years of family medicine training, with a paucity of inpatient rotations, by the way, there's very little rotations on internal medicine and emergency medicine. They can do a 1-year family medicine anesthesia training in a program. And after 1 year of anesthesia training, they are allowed to practice and are supposedly restricted to ASA1 and ASA2 patients. And across Canada, there are approximately 20 graduates a year. And these individuals work in places like Sioux Lookout, small communities in Northern Ontario. If you're one of the large hubs like Sudbury, Sault Ste. Marie, you're very likely to be a fellowship anesthetist now, but there are still family practice anesthesia providers in those centers. And again, they're more like my age. And there is a slight shift in these northern centers from family practice anesthesia to fellowship anesthetists. But it's surprising that to many people outside of Canada that someone with only 1 year of training can provide general anesthesia care, and particularly for obstetrical anesthesia. Most of the anesthesia provided in Canada is from fellowship anesthetists. This is graduation from medical school, 5 years of post-medical school training, PGY 1 through 5. Again, I'm from a different generation where everyone qualified as a general practitioner, and before they would go into a residency. And then once you finish your PGY 5-year and successfully pass the Royal College exams, which are about 120 graduates a year across Canada, to practice cardiac anesthesia, cardiothoracic anesthesia, is 2 years plus more if you wanted to practice intensive care medicine as well. So at the university level, less than 5% of my job is keeping patients asleep. And I think sometimes non-anesthesia providers don't understand that. 95% of my job is keeping the patient safe. So anesthesia is a triad of hypnosis, analgesia, and exposure, but it's also maintaining perfusion to vital organs, ensuring that the patients have adequate perfusion to their brain, their lungs, their kidneys, and their liver. I have to make sure that they can wake up and that they haven't lost any function from the pre-op state. And that my job is with the cardiologist to optimize patients for complex surgery and to manage safely their post-operative care and recovery. These models differ depending on the model you're in, whether you have a pediatric centered program or you transition to an adult congenital program. You have to find a model that works for your university and center and for your individual hospital. and work with that. So what things do I worry about that a cardiologist may not worry about? I always worry about airway, and often we concentrate on whether or not someone's a difficult intubation, but I would suggest that anyone who's a difficult intubation is a more difficult extubation. People are generally more swollen after surgery, and remember that patients are in a vulnerable state when they wake up from a general anesthetic, and they have to be in a supervised and monitored environment if they have a difficult airway. Are they in a place where someone can rescue them if they get into respiratory distress, and the person rescuing them is an expert in providing, is able to secure the airway? I have to think about patients who may be at risk for prolonged ICU stay with paralyzed vocal cords, subglottic stenosis, restriction of their pulmonary physiology, and a difficult vent wean. Many adult congenital heart patients have very difficult venous access. They've had cut downs of arterial arteries in their forearms. Many patients will have transverse scars over their radial artery and brachial artery. And we have to plan and share access. So many adult patients may need a free flap. They may be breast cancer and need a free flap to cover the defect, or they have head and neck cancer. Many of our patients have absent femoral vessels from cannulations in the past. Pain and management post-op, it's very important to keep in mind that minimally invasive surgery is always the desirable choice, but it often involves insufflation of CO2, which makes my life difficult in the operating room. However, better that I have a difficult time and I can manage you intra-op. Post-op, if you've had an open procedure and we give you IV PCA, that means an intravenous patient-controlled analgesia, you hit a button and you get a shot of hydromorphone. You know, many of our patients are dependent on a low pulmonary vascular resistance. So if they're hypercarbic from respiratory acidosis, that may not be very good for their circulation. Epidurals, also good, but you have to keep in mind that it may drop their systemic vascular resistance. Monitoring post-op, again, you have to pick a solution that works for your hospital. Some hospitals have integrated coronary care units in ICUs. Others have separate ICUs, much like Toronto General Hospital. We have a CCU and we have a CVICU and we have a med-surg ICU. So those are things to consider in positioning. So the next slide is positioning. So you have to, when you do the consultation, think about the congenital heart disease that the patient has, and what are the physiological consequences of being 45 degrees head up? What are the physiological consequences of being 45 degrees head down with positive pressure ventilation? Do they have a VQ mismatching? Is there a problem with line on one side? So if the patient has a differential in pulmonary artery blood flow from PA plasties in the past, and they're going to come for a nephrectomy or a thoracotomy or something in the lateral position like a hip replacement, you have to remember that, oh, maybe I should roll them on that side and make sure that they can oxygenate themselves. These are all very practical, simple things, but you have to think of them. And what if someone's in the prone position, or this is called a park bench? How are you going to rescue this patient? How are you going to do CPR in this patient who's got their head in pins and their head is suspended and there's nothing compressing here? There's no way you can do chest compressions on this patient. So all things to think about. So when I see the patients well ahead preoperatively, I think about these things and I try and manage the team and manage the environment around the patient. But just before it's time to go into the operating room in the holding area or the night before, it's like you're going on holiday and you're on the airplane and the plane's on the runway and the seatbelt sign is on. So now it's time to go into the operating room, whether it's cardiac or non-cardiac surgery. And these are just simple rules. Accidents happen in transitions. So induction, emergence from anesthesia, and transfer to the ICU. So you can have accidents in physical transitions, like moving from one bed to the other and with minimal monitoring. That's when your patient has an arrhythmia. Or in communication transitions. So you've moved from a surgical environment to an intensive care unit environment where they're internists or respirologists and may not have the appreciation of the cardiovascular nuances that, say, Irwin and Rafa may have. So also intraoperatively, where will the case bite you? Where are the critical moments where there's a conflict between the physiology of the patient and the anesthetic care? Work backwards from that and try and mitigate or prevent that from happening. Always, always, always pick a less complicated plan over a complicated one. If you have a very complicated anesthetic induction and plan, you won't know if the patient's hypotensive from your very complicated plan, or is it the patient's physiology that's failing. As always, start clean, all lines and catheters, particularly for cardiac surgery and if you're implanting conduits. And if you're going to go through life with one ventricle, always choose a left ventricle. So common errors and pitfalls in anesthesia. Hypoxia. Hypoxia is not always due to the patient's congenital heart disease. It can be for any of these reasons. So whenever I see a patient with decreased oxygen delivery, yes, I think of shunting. But I also think of all the other practical things. Is the tube endobronchial? Have I put the endotracheal tube too far into the trachea and it's down the right main stem bronchus? Do I have adequate minute alveolar ventilation? Have I created a situation where I've exacerbated VQ mismatching? Not much I can do about diffusion capacity in the operating room. I always think about shunting. Think about cardiac output. Can I augment the cardiac output and oxygen delivery? And particularly for congenital heart disease patients, do I have a high enough hemoglobin for this patient's physiologic state? And if they're in a state where they have increased extraction, is there something I can do to minimize extraction or alleviate it? So just to highlight, this is a common error that non-cardiac anesthetists will make in caring for a patient with a left to right shunt. They'll think, oh, it's a simple cardiac lesion. It's just an ASD. But I'm going to take really good care of this patient, so I'm going to induce them on 100% oxygen. And because they have heart disease, I'm going to leave them on 100% oxygen. Ooh, well, not so good, because you're going to exacerbate what is a left to right shunt that's 2 to 1 or 3 to 1 and exacerbate it to a 5 or 6 to 1 shunt and cause hyperperfusion of the lungs and very little systemic oxygen delivery. And ironically, you'll have a pink patient with a severe metabolic acidosis. Similarly, if I'm a patient with an unrestricted left to right shunt from AP collaterals, I have to imagine I'm a red blood cell and I'm sitting in this large aorta with AP collaterals coming off both pulmonary arteries in this patient are coming off an aorta, and they're the size of my thumbs. So yes, induce this patient on 100% oxygen, but as soon as you've induced them, aim for their room air saturation in their ambulatory life when they're well, because they've sorted themselves out. If they're able to do the grocery shopping with a room air sat of 82, they can survive your surgery with a room air sat of 82. And you want to maintain a balance between the pulmonary perfusion and the systemic perfusion. So this is a patient with truncus arteriosus. Again, this is a patient that has essentially, from my point of view, a common ventricle. I realize there's 2 ventricles here with the VSD, but you have to imagine that you're a red cell just below this truncal valve into the truncal artery, and that this patient's come for a non-cardiac procedure, and you have to imagine how do I find that balance between the systemic circulation and the pulmonary circulation. So again, I would aim for the patient's room air saturation, and I would ventilate them to keep the PaCO2 as close to 40 as possible. Next slide. All right, gravity's free. We don't pay for it. This drives me crazy. So always de-air your lines. And whenever you run an IV through, if it's a congenital heart patient, I run the IV for myself and I let it sit for 10 minutes, and then I go and I aspirate all the air bubbles. So you can see the person on the left is injecting and they're letting the air bubble go into the patient. So why not just turn it upside down, bang the syringe, and let the air float to the top of the syringe before you inject. Many of our patients will have air filters in situ, but it's very important to remember that yes, it's important to have filters when they're on the ward, but propofol and blood will not go through these filters. So if you have both arms tucked in for a major general surgery or vascular case, and you've injected a drug like midazolam or propofol, you've now stopped your IV from working and you have no IV access to the patient. And in the middle of the operation, you're going to have to either untuck the limb or put in a neckline. So, I mean, it sounds pretty obvious, but these things happen. So shunting, this is Irwin's patient, and this is a study I did with Irwin. So you have to remember that blood flow from the IVC preferentially goes against the septum. And so this is just demonstrating blood flow injected into a vein in the upper body, and propofol agitated with some blood is the contrast here. And you can see that this patient has minimal shunting when the drugs are injected from the SVC. So I'll stop that one and then we'll play this one. So here you can see what happens when we inject contrast from the lower body. So I put an IV in this patient's foot and we can see that the patient's shunting substantially right to left. And so you have to remember that. What if the patient's in a procedure where they're 45 degrees head down and they can entrain air from the surgical field? You have to think about these things. You have to imagine that you're a bubble of air coming up the IVC and going against that intra-atrial septum. And shunting can be drug related as well. This is a patient with Ebstein's anomaly. So we all know that patients with Ebstein's anomaly are very dependent on low pulmonary vascular resistance. And so this patient had an Amplatz device in her mid-teens to close her ASD, and she has you can't see it here, but you'll have to take my word for it, that she has a typical Ebstein's-like valve. And with an exuberant induction of anesthesia, this patient dropped her SVR and shunted right to left and dropped her saturation substantially. This case was aborted, but this is another good example. This is a patient with Ebstein's anomaly, dependent on a low pulmonary vascular resistance, scheduled for a procedure where there's going to be insufflation of carbon dioxide. So the good news is that this patient actually woke up and was fine, but we had to abort the case, and it seemed very unsuitable for a patient with insufflation of CO2 if she couldn't even tolerate the induction. So when people ask me about pulmonary hypertension, it's not just a one-stop answer, and this is an example. So the most common type of pulmonary hypertension I see in my practice is pulmonary hypertension from a failing systemic ventricle. So this is a patient with congenitally corrected transposition with a morphological right ventricle as a systemic ventricle. So if this patient has pulmonary hypertension, it's not that different than my patients with mitral regurgitation, ischemic heart disease, and non-compliant ventricles. Their pulmonary hypertension is from a failing left-sided circulation. And that's managed very differently than these patients. So this is a patient with a large left to right shunt and a volume overloaded right ventricle. This patient may benefit from inhaled nitric oxide or dilators. And this patient you saw before. This is a patient with Eisenmenger's and with a very thick ventricle and pulmonary hypertension from an unrestricted left to right shunt. So you have to treat the root cause. They're not all the same, and there's no one recipe for any of these patients. I have to stop this and move forward. Moving forward. Okay, so let's do some examples. This is tetralogy of Fallot. I have to apologize ahead of time. This echo clip does not match the patient I'm going to tell you about because I couldn't get, the hospital seems to be overwhelmed with the Zoom meetings and Microsoft Team meetings, and I couldn't get Singo to work on my computer last night. So I don't have to tell this audience that adults with tetralogy of Fallot who've been repaired in childhood have dilated RVs, pulmonary regurgitation, and restrictive lung physiology and congested livers. So this is a patient I saw yesterday. It was a telephone consult, but I've met the patient previously in the past, and he's coming for surgery next week. So this is an example of his comorbidities are as important as his cardiac diagnosis. So tetralogy of Fallot repair, he's had multiple RV to PA conduits in the past, and he's had 4 sternotomies. He also has Vactral syndrome, and so he has scoliosis, restrictive lung physiology. He has both anal and urological issues and has to self-catheterize, and also has a seizure disorder. And what he's coming for next week is release of a tethered cord in the prone position. But sadly, just for a routine cystoscopy and dealing with one of his urological stoma last year, he had a PA arrest under anesthesia. And it was found post-op, he was resuscitated successfully. Sadly, he had an extravasation of resuscitation drugs into his IV in his left arm and has a burn, and so has limited IV access now. Was admitted and ventilated for 24 hours in the hospital. And we really didn't find a cause of the arrest, and it's presumed that he had a vagal stimulus and asystole from dilatation of the urological stoma. But negative workup for cause. And what's also more concerning is he reported 2 episodes of sudden onset of diaphoresis and paleness while standing associated with presyncope, but no loss of consciousness. So we have to go back and think, oh, we're going to do this case in the prone position. So we have to think ahead of time. How are we going to rescue this young man? So he's going to be in the prone position. You can see that this is not a position that's quite suitable for CPR. So we have to have a stretcher in the room right beside him to rescue for flip. We have to think about the ordinary things like the face and eyes, but that's not unique to congenital heart disease. But we do have to think about where we're going to put the pacing pads, where is the defibrillator, where are we going to put this patient post-op? Do they have safe harbor and a place where someone can rescue and resuscitate them? Tetralogy of Fallot and carbon dioxide. So this is an easier case. This is a gentleman who is of large stature, And you know, 25 years ago, if you said to me I would be seeing patients like this, I'd be shocked, because most of my patients 25 years ago were thin. And now I regularly do consults for feasibility for bariatric surgery. So bariatric surgery involves insufflation of CO2, but it's much easier to do than the case I just showed you or the case I'm about to show you, because they're 45 degrees up, head up, the abdominal contents are down. It's easier to ventilate the patients. It's a short procedure. So yes, you can do PVR-dependent patients with free PI or Epstein's patients with tricuspid regurgitation with insufflation of CO2, but you have to do it very carefully and have agreed thresholds with your surgeon about what inflation pressures you'll use. You have to do it with an arterial line and follow oxygen saturations and pH. This is a straightforward patient. This is someone who's coming back for cardiac surgery soon, who's got RVOT obstruction. But he was repaired it's a tetralogy of Fallot patient, repaired as a young adult, lost to follow-up for 20 years. And interestingly, the cause of his kidney failure was hypertension. So this is a good example of where we have to be better at keeping our patients inside the tent. And also that patients can get ordinary adult comorbidities. So hypertension is something that we manage very well in the adult acquired community. And so we have to remember that our adult patients can have the same comorbidities as the patients who don't have congenital heart disease. So here's a good example of management of a patient with an airway and restrictive lung disease. So this is a patient who had pulmonary atresia with a stenosed RV to PA conduit. So a 2-ventricle repair. So she's going through life with 2 ventricles, but she does have a right ventricular systolic pressures near systemic and AP collaterals. So this was, again, a good example of, with careful team planning, we were able to do this young woman who had significant airway considerations, significant pulmonary restriction, and central sleep apnea. She had her lap chole, did well, and was out of the ICU within 24 hours, and did very well, and her cholecystitis was debilitating. So Epstein's, again, this is a good example. This is just a nice echo clip of an Epstein's. So they have a dilated atrialized right ventricle, ASD, reduced RV function, and are very dependent on a low pulmonary vascular resistance. So what do you do with a severe Epstein's that needs a procedure that is usually done in a non-tertiary care hospital? And this is an example of someone who has had 2 surgical interventions for Epstein's and 3 ablations for atrial tachyarrhythmias. She was brought into the operating room. She showed up at a community hospital and was said, "Oh, I'm sorry, you can't have the surgery here," and that was appropriate. And it was a good example of a good catch by an anesthetist in the community saying, "Oh, you've got to go see your cardiology friends." She's a college student. She graduated from the Sick Kids program and was doing what young adults do, living her life and enjoying herself, but she wanted to have a breast reduction. So she was referred to us, and after the IV and arterial line, she had tachyarrhythmias. And this is a difficult one because it's a good example of planning, because this is an operation where there's no good place to put defibrillator pads and pacing pads. So there are challenges, and there are sometimes that you have to just say, "No, I'm sorry, I don't think we can do this safely." Okay, so this is an easy one. Transposition, where you have a systemic right ventricle. So if you're a Musting or Senning repair or a congenitally corrected transposition of the great arteries, although the anatomy is very difficult for non-cardiac anesthetists and non-congenital cardiac anesthetists to process, once you process it, my advice to these patients is manage these patients like a non-ischemic dilated cardiomyopathy. So although the anatomy is complicated, and yes, there are special nuances like congenital heart block, these patients from a hemodynamic point of view are not that different from for me to manage than someone who has a non-ischemic dilated cardiomyopathy waiting for a heart transplant or in a heart failure program. How are we doing for time? So just anyone volunteer if I should stop talking, because we're at the 8:45 mark. I just have a few more slides, and I love answering questions. So I'll just keep going here. So let's talk about Fontans. Everybody loves to talk about Fontans. So using Dr. Morelli's data from her paper in 2014, I estimate there's 500 to 600 Fontans over the age of 18 out and about in Ontario. Okay, so we'll keep going. And so this is an example of a 38-year-old female, double inlet RV. This is a patient of Dr. Coleman's who's had both an ovarian tumor removed under insufflation of CO2 in the 45 head down position, and has had a cholecystectomy in the head up position. So she's a wonderful example of what a good Fontan looks like, and how with careful planning and you can do procedures that involve insufflation of CO2. Special mention though, you have to remember that when you are head down and you're a Fontan, your venous pressures are much higher because you're going to have sort of a column of blood going down your lateral tunnel or your extracardiac conduit, Fontan. So your venous pressures in your head are very high, and yet being head down with insufflated CO2, maybe your cardiac output is not optimal because there will be a challenge for the red cell to get from the main PA to the left atrium with a high CO2 in the positive pressure ventilation. So you have to remember you may have to augment cardiac output because cerebral perfusion pressure may be compromised. You'll have a high, you're a red cell going through the cerebral circulation, so you have to augment forward flow, augment cardiac output, remembering that the venous pressures in the jugular bulb will be higher than they would when this patient's sitting up. There's a sonar sound here. All right. And I think I showed this slide last time I was here. This is I love this slide because our patients have won the race. This is a 49-year-old Fontan circulation needed hip replacement. So I think in the interest of time, I'll just skip through this. This patient had a spinal anesthetic and nothing bad happened. And I just want to talk about cardioversions. So do not be casual about cardioversions. In some ways, it's much easier to do that previous slide because I'm in the middle of the main OR and all my friends are around me. And sometimes the advantage of a teaching hospital isn't that people are smarter in teaching hospitals. It's just there's a lot more people around that can come rescue you if you get in a situation. Cardioversions can be fraught with complications. And you have to remember that they're often done in places that are remote from the main heart of the hospital. So you have to imagine that when a patient shows up with a tachyarrhythmia, you have to make decisions about whether it's safe to do it in a location like Emerge, or should you bring the patient into a central monitored area, or should you even do it in the main recovery room of your hospital. And again, you know the architecture of your hospital and where people are best suited. So this is a good Fontan, and you can say, well, this is a little different cardioverting this person. But I want everyone to imagine that you're in Emerge and you're cardioverting someone with an atrial arrhythmia and you're a milligram of epinephrine, and it's just going to circulate here in this large lake of a Fontan connection in the right atrium. This is a classic Fontan. So cardioversions are not to be taken lightly. I always put a large bore IV in. I always tell a friend where I'm going. I tell them if I page you to the CCU, this is what I'm doing. Just come, don't call, to find out what's happening. And similarly, for when you're fielding these phone calls, it's a difficult decision because the patient may be very ill and may need to be cardioverted in situ where they are in the community hospital, but you have to support your colleagues on the telephone. And this is not just a cardioversion. Yes, they're only asleep for 5 minutes, but there can be severe consequences. So finally, I'm going to spend the last 3 minutes talking about vulnerable adults. Very important that you have a plan, and that you have to make sure that these patients have to come back for their appointments. So it's important whether you use oral midazolam, IM ketamine, inhalational induction. I prefer actually talking to them and using IV inductions and using electronics to get them to calm down. Engage their caregivers and getting them into the diagnostic facility or into the operating room. Because remember, if you use IM ketamine, it really hurts. It's 4 milligrams per kilo, and for someone my size, and I'm not very big, that's 3 cc's, 3.5 cc's of an IM injection. That super hurts. So it may work once, but it's not going to work the next time. They're going to remember that, and they're going to remember you. So it's very important that with vulnerable adults that we make sure that we not only are successful for this induction or this test or this procedure, that we engage in a relationship where they're going to come back the next time and that they're not frightened of coming through the hospital door. And I think I've come to the end of my slides. So in summary, facilitate patient-centered consultations, flag and identify comorbidities that are in conflict with either the cardiac surgery or the non-cardiac surgery. Remember that all of our patients are normal teens, and often as anesthesiologists, we may encounter someone that has been lost to follow-up, and that it's very important for us to re-engage them with the team. But also remember that there's lots of stuff that we do in the operating room that, you know, as a cardiologist, it's not that there's a magic recipe that you can tell an anesthesiologist what to do. Mostly think about the physiology, and that we pick a plan that matches the patient's physiology and the procedure that they're going to have. And that's it. And I'm happy to take any questions.
Thank you,
there's Dr. Williams. Yeah, thank you.
Thank you for the excellent talk as usual. So if you have any questions, just type them on the chat, or you can unmute your microphones and ask questions to Dr. Heggie directly. While you're thinking your questions, then I have a question. So you stress, I think enough during the presentation, that patients with at least moderate or moderate and severe congenital heart disease have to be, at least if they have any non-cardiac surgeon, so non-cardiac surgery should be majority of the time done in a center, with a specialized center with cardiac anesthesia with expertise in congenital heart disease. What about the simple congenital heart disease and the ones that are moderate, but you know, which will be your line or your threshold to let a patient to have a hip replacement or a hernia repair somewhere that is not a center with expertise in congenital heart disease?
Well, I think that you know, we're going to have to draw these lines, because if there's 90,000 patients with congenital heart disease, we won't even be able to talk on the phone about all of them. But I think that you have to look at, is there a potential for shunting? Do they have pulmonary hypertension? Any history of hemoptysis for sure. And what is their systemic ventricular function? And do they have any malignant or problematic arrhythmias? So like if you have a pacemaker, for sure, you've got to be done in a center that can reprogram your pacemaker, right? And I would say no to ambulatory facilities across the board. So a good example of a Fontan needs wisdom teeth extracted. Okay, you don't have to come all the way to Toronto to get your wisdom teeth out if you're a good Fontan. But rather than doing it in the oral surgeon's office, could you do it in the hospital with an anesthetist on standby? That would be an example. Or a patient with a moderate sized ASD that is waiting 18 months to get an MPLATS device. And they need that's an example of a very simple lesion, but it can go pear-shaped if you put a spinal anesthetic in that patient, because that you may convert a left to right shunt to a right to left shunt. So that's something that could be managed with a friendly phone call and strong advice about not using regional.
Mm-hmm. And one question is another question. So in terms of visiting the patients before the anesthesia, so you here see every single patient that go for non-cardiac surgery, and you see every single patient that go for cardiac surgery before the procedure?
No, well, not me. One of my team.
I mean,
yeah. One of those 4 people. Yeah.
I think I know the answer to that question, but just I think in terms of the model that we have here, would you mind to explain the audience what is the model that we have here in terms of how we deal with pre-anesthetic clinic, anesthetic assessment of all our patients?
Oh, sure. Yeah. So we're members of the adult congenital heart team, and there's at least one of us at case conference every Monday. So we participate in all of the discussions of patient management, but particularly for patients going for surgery or for significant non-cardiac surgery, we have a clinic once a week where we see all of these patients. And for the cardiac surgery patients, ideally we want to see them 4 or 5 weeks ahead of time to flag comorbidities. So sometimes I can optimize the comorbidity. Other times I can optimize it, but I can better define the problem and risk and involve, say, hepatology or ancillary services to follow the patient with us. So an everyday example is someone has 20q2 deletion syndrome and they have schizophrenia. Well, I'll have consult psychiatry see them pre-op and we'll have a plan. So it's not just taking care of their heart, it's also making sure that they wake up without delirium and that they're not traumatized by the experience, and that we can transition them to their oral antipsychotics fairly quickly. And what things can we do to mitigate the psychological trauma? Patients with restriction that's significant, I'll often counsel them about a tracheostomy ahead of time and warn them that they may have a prolonged vent wean and what a tracheostomy is and why we do a tracheostomy. What we do this, and instituting this clinic about 5 years ago, but in no, it's not just this clinic. There are many things we did in the surgical program, and the introduction of fibrinogen concentrate and plasma. There are many things that have changed for the cardiac surgery patients in the last 5 years. Mortality and morbidity has dropped significantly. But the idea is that if you see the patient and there's things you can optimize them 8 weeks ahead of time. So you're planning your holiday, you're looking at where you could go, and you're deciding, should I go to Europe, should I go to the Caribbean, should I go to South America? So this is a clinic where you do the planning, and then if you can't optimize the comorbidity, at least you can control the environment around the patient and manage the comorbidities or mitigate them as you go. But once you see them in pre-admission clinic the day before to get their cross-match and their COVID screen, you know, it's too late now. The seatbelt sign is on and the plane's taking off. So that's too late to have these heavy discussions. The other thing that we have to, sorry, I'm the director of the ICU. So it's also very important to iron out who's the substitute decision maker. So this is fairly common that I have young adults that are having surgery and their parents are divorced and not on speaking terms. So you got to iron that out ahead of time. Or they're newly married and the parents are happily married, but the parents have seen them through 5 previous cardiac surgeries. And it's not that there's conflict, but you have to kind of gently educate the parents that you'll be involved in decision making, but it's their spouse that will be their substitute decision maker. And all of these things smooth the bumps if there's a problem with the admission or they have ICU morbidity.
Thank you, Jane. So one thing that I want to stress and I find extremely helpful in our program is that also the anesthetic team is the same team that evaluate our patients before heart transplant. So we are the decision making in the heart transplant assessment is the same for the same team that makes the decisions in terms of whether or not we're going to proceed, and it's the same surgical team and the same anesthetic team and the same cardiac team, which makes a huge difference in terms of the management of these patients. So do we have any other questions? Okay, if you don't have any other questions, it's 9 a.m. So thank you very much for joining us today and for the excellent talk as usual. And thank you all for joining us for wherever you are in the world, and see you here next week. So good morning, good afternoon, or good evening, wherever you are. Bye-bye.
Thank you. Thank you. Goodbye.